All right, today I'm with Dr. Roeca. Thanks for being here, Dr. Roeca.
Yeah, thank you so much for having me.
Yes, this is so fun. I appreciate you saying yes to being on my podcast. And we're going to be focusing all about fertility preservation today. And you are a reproductive endocrinologist here in Denver with Shady
Yes.
Grove.
Mhm.
And if you could share a little bit about your background to kick it off, that would be awesome.
Sure, yeah. I'm Dr. Cassandra Roeca, go by Cassie. I grew up actually in Colorado Springs. And then being a Colorado native, I went to Boulder for undergrad. I studied molecular, cellular, and developmental biology there. And then I ended up going to medical school at University of Colorado as well, and did my residency in OBGYN at Harvard at Brigham and Women's Hospital and Mass General Hospital out there. And then returned to Colorado for my fellowship training for reproductive endocrinology and infertility. And then was happy to stay on with the team at University of Colorado as assistant professor in RAI, and then joined Shady Grove Fertility as of June 2021 to help open this practice. And
Okay.
so now I have, clinically I work here at Shady Grove, and then have like research faculty appointment at the university still. So
Awesome. Yeah, I too am a Colorado native. I love that. You have a lot of Colorado roots here.
yeah.
And you and I connected at a recent event with Colorado Fertility Advocates, which I know you're a big part of.
Yeah.
And that was during National, I like to say Fertility Awareness Week instead of Infertility Awareness Week. But can you share a little bit? I know your background, you're very passionate about fertility preservation and helping patients with cancer and other medical diagnoses that place them at risk for infertility. How did you even what led to that passion to even pursue this kind of work? Was it a personal background in or I'm just curious to know a little bit further, what even made you pursue this path?
I think it started when I was an OBGYN resident. I see you see a lot of trauma in OBGYN, and a lot of people suffer through trauma that occurs on labor and delivery in trying to save mom's life, trying to save baby's life. And sometimes, for like severe hemorrhage, abnormal placentation, people end up losing their uteri, losing their uterus altogether. And it was pretty devastating, and the toll that had on patients who still wanted fertility options for the future. And then because they had to have this procedure to save their life, suddenly find themselves unable to. And so I worked a lot with that patient population, had a big interest in abnormal placentation, something called placenta accreta.
I had that.
Okay.
I didn't realize that was your kind of passion in that area.
Yeah. And I had a great mentor who I worked with. Her name was Danny Carusi at Brigham and Women's. And so published some research with her. And I think so that's what initially sparked my fertility preservation interest.
Okay.
And then I got more exposure in fellowship training to the oncofertility population and patients who have a cancer diagnosis, a different type of trauma, and are suddenly being told, hey, you're going to get this chemo. And if you don't freeze your eggs right now, then, you might not be able to have any kids in the future. And what we know about cancer is more people are surviving their cancer and living lives where they can have pregnancies and see having, families and being able to achieve that. And so being able to help preserve those options for people and making sure that they're educated about those options and that they have access to those options is something that I became very passionate about. Because it kind of felt like a slap in the face having conversations. Hey, here's something we can offer you. Oh, by the way, it's going to be thousands of dollars. And I know that you have all these other things on your plate right now. And hey, can you afford this tomorrow?
Oh my gosh.
Really difficult. And it's a slap in the face to be able to offer something and just dangle it in front of them without also being able to help offer resources to cover those costs too. And so that became something that I really wanted to help. And Dr. Leslie P., who's come to the university, has really helped strengthen that program as well. And we work with other companies such as Chick Mission who help provide grants for patients who come to us who don't have their own fertility coverage, either through the Colorado Building Families Act or through their independent employer, to be able to help cover the cost of those. So we really try and tackle multiple ways that we can help those patients, and then, be able to get them in quickly, seen and taken care of, and, give them the best chance that they can for having options in the future. So, and then as a physician, I care strongly for autonomy for patients to be able to build families how they want, when they want, and particularly knowing that people who pursue, really any career. But I know as it pertains to my specialty, people who go into medicine do have increased risk for infertility. We see 1 in 4 female physicians struggle with infertility.
That's really high. That's high.
Yeah. So, being able to help, people who are delaying their family building because they're passionate about pursuing their careers, and being able to provide and educate about those options as well is also something that I've become very passionate about. And so I think those are the different ways in which I've been shaped to really, really help and provide care and access to fertility preservation services. And something that's unique about Shady Grove, we started a surgical residency initiative. So it's a program that helps provide actually discounted egg freezing for surgical residents, knowing that, they spend a lot of time in the hospital. They're there for very long hours, extended training times, and, a population of women who might be potentially more vulnerable to ovarian aging and things like that. So we do have a program that helps decrease the cost of egg freezing for surgical residents who are currently in training.
Wow, that's incredible. Yeah, I'm so glad you're touching upon this. There's a lot of questions I have going through my mind. I have had a few clients, many in the medical space, and I'm curious, why do you see just women delaying their plans to grow their families longer, like the stress of the medical environment, the crazy work hours, like you said? I mean,
yeah. Well, so what we know is the number one barrier for starting family is not having a partner. So, and then being in a position where you're kind of in the hospital all the time certainly does limit your ability to get out and socialize, find somebody, who maybe don't work directly with. And so, and then finding time, even to find 2 weeks to be able to come and go through this process for someone who has to be in the hospital like 5:30 and, is going to be on call for however long, it's really difficult. So, having a partner is certainly a barrier, but then, delaying childbearing for career opportunity. And then in general, the trend for people just waiting longer to conceive.
Okay. Wow. Thank you for touching upon that. And would you say the diagnoses that you see most often, and you're passionate about helping those who do have a cancer diagnosis, is that typically one of the biggest areas that do you work alongside an oncologist, or how does that work? Can you kind of guide us through that process?
Yeah, so we just try and educate like any oncologist in the area. If patients are going to be going through any kind of treatment that may impact their fertility, and that depends on the type of treatment, whether chemotherapy, the type of chemotherapy, how long it's going to be given. If there's going to be radiation, where that radiation will be delivered, for how long. These are all things that we take into consideration to help educate a patient on what their risk would be, and whether they're at high risk for ovarian failure following that treatment, high risk for infertility following that treatment, or low risk. And do we have time? Is the patient capable of being in an outpatient setting and doing this for the 2-week period prior to starting that treatment? Do we have time, or is, there are situations where a patient has to to start that day, just depending on the severity and what the diagnosis is. So a lot of times, it's about working in concert with oncologists, radiation oncologists, and knowing that these options are available. Many organizations, including ASRM, recommend that anyone with a new cancer diagnosis, regardless of age, whether pediatric, adolescent, or, anyone of reproductive age really should be offered a fertility preservation consult so that they know what potential options and risks to their fertility might be with that treatment.
And these oncologists are pretty aware of, talking about this with their patients, or do you see that they're not? I don't know.
So the data suggests that historically these conversations have not been had as often as they should be, but the fertility preservation program at the University of Colorado has been working really hard to help educate. And it's not just those, it's other medical providers. People might have lupus, sickle cell, other things that they might have to take medical regimens for that could have an impact on fertility as well. And so trying to figure out where are these patient populations going, how do we educate those providers, and then give them quick, easy ways to refer the patients, and then ensure that we can see those patients quickly.
Yeah. We all know how long sometimes it can be to wait to get in to even get a consult with a fertility doctor. So in those cases, can I ask, do you all make kind of exceptions? Like, oh, someone's like on a time crunch. We want to get these people seen and get support now.
Yeah, absolutely. So, typically we will try and get that referral in, within 24 to 48 hours.
Oh, that's awesome.
Yeah. And so we're usually trying to, if necessary, fit things between the cracks and, make sure that we can get patients seen and use all the resources in our office. We also have other REI fellows who can help, with getting patients in quickly as well to be seen. So, that's what we do here. And then we have a fertility preservation team that we partner with at the University of Colorado. So that's, again, a way for us to figure out, where does this patient need to go? Who do they need to see? What's the best way for us to get them the care they need, like ASAP?
Can you guide us in a couple different scenarios? So like for a woman, you're looking at, egg freezing, you're looking at, for men, are you looking at preserving sperm? Can you kind of share some of those different situations?
Yeah. So for women, there's, egg freezing. Generally, if you don't have a partner or haven't tried to conceive or hadn't been planning on conceiving, and that's the best way to help maintain reproductive autonomy. You can create embryos in the future with whatever sperm source you want. Then embryo freezing is an option potentially, if somebody's already been trying, or if they already have biologic children with a partner, or if they had intended on having children with this partner, very recently, would be indications for embryo freezing.
Okay.
And then we also do ovarian tissue cryopreservation. So some patients, again, aren't going to have time to go through that 2-week process. And so those might be candidates where, if they're very high risk for ovarian failure from their treatment, they'll actually go in and remove an ovary and preserve tissue that could be reimplanted into the patient's pelvis later on.
That's incredible. Okay. Wow. So you can preserve the ovarian tissue. What are you taking out? What are you preserving exactly?
So you take out the ovary and then you shave off the outer cortex layer and you preserve those pieces. That's where the little follicles and the eggs reside mainly within the ovary. And so those can be cryopreserved, and then later you can take those little strips, put them back into the pelvis, and people can actually, if you put them close to the fallopian tubes, resume their prior ovarian function, start ovulating, and then be able to actually conceive spontaneously.
Oh my gosh.
So there's been, well over 100 reported live births of this. And ASRM several years ago lifted the experimental label for it. So this is something that they do offer at the University of Colorado. And so Dr. Apia leads the team in those efforts there.
Oh my goodness. That's fascinating.
Yeah, it is. And then for guys, they can do sperm banking. The caveat is that you have to be, really pubertal to do that and to be able to actually have an ejaculate that has sperm in it.
Oh.
Some patients might be very sick and they're actually not able to ejaculate. So, or they just, because they're so sick, have, very few sperm available, things like that. So try and work with again, the fertility preservation team at the university works with urology closely for some patients where actually like extracting sperm directly from the testicle might be needed from the epididymis. If a patient's unable to provide a sample, or currently they have an IRB to collect testicular tissue for patients who are prepubertal. Because they're promising studied in non-human primate models that preserving testicular tissue and then transplanting it later could actually potentially, cause testicular function to resume. But that one is more experimental currently.
Wow. And what the ages? Who is the youngest kind of girl, boy, young, young woman? Who? What's the youngest age that you've preserved some eggs? Is there an age
that we've preserved eggs? Well, that we stimulated adolescents. So, we've had people who are 12 or 13 who have done the ovarian stimulation to get eggs.
Okay.
It's a difficult process though. And,
wow.
So, it's obviously a lot for parents and the kid to be thinking about.
Wow.
But we try and provide as much support as we can to, help make that a feasible option if that's something that the child and the parents want to pursue. And then in terms of sperm banking, again, it's just a matter of seeing like, can they produce a sample or not? And then, we have kiddos in the single digits that I know Dr. Apia's team has been offering the testicular harvest to.
Okay. And so for the most part, you would like to see them first and then they would go through their cancer treatments typically?
Yeah. So the idea is that you want to preserve those before they do the therapy that will be toxic to them.
Oh my gosh. And it's very expensive as we were talking about some of those programs. So that's wonderful that the university is kind of assisting and with the law, with the Colorado Family Building Act, are you seeing that being covered more?
Yeah, I really am. So it's great because Shady Grove has a partnership with Chick Mission. So if somebody's not covered through their insurance, then we have grants that will essentially help cover that cost completely. And so there are, some pockets of patients who were still unable to help, but the majority of people who walk in our door usually have either some kind of coverage or qualify for the grants that we are able to help. Okay. And then we do have a nice program for anybody who freezes eggs here at Shady Grove and has 10 or more frozen eggs with us. They can qualify for our shared risk egg thaw. So when you thaw those eggs, you either go home with a baby or you get your money back. Since many people who are doing fertility preservation consider it an insurance policy. But you've probably heard stories of people who froze their eggs, but then were not able to get pregnant when they tried to use them. And so, we have our own rates that we share with our patients and counsel, hey, the younger that you are and the more eggs you have frozen, the better the chance of a live birth. Okay. It's never a guarantee. Right. But, we do a good job of it. And with that, we can essentially provide like a money back guarantee to our patients that the majority of you who have this many eggs frozen with us, are going to go home with a live birth if you decide to use those in the future.
And is it up to 3 rounds or how many?
For shared risk. So you would have to thaw at least the 10 eggs.
10 eggs. Okay. That could be a whole nother conversation. Right. Shared risk. Let me see here. So you mentioned lupus and sickle cell. Are there other kind of diagnoses that come to mind that you've worked with or other individuals?
For medical diagnoses.
Yeah,
Mhm.
for the
Yeah,
nation.
so another example is like endometriosis. So something where people might be at risk of surgically having their ovaries removed for severe endometriosis. So those are things where they're not planning on having kids right now, want to have it as an option for the future, facing potentially worsening endometriosis and potentially surgeries that are going to remove their ovaries. So that's a situation where we're going to go in and try and help preserve the fertility we can before potentially those processes would take place.
Okay.
Mhm.
That's helpful. I know. Yeah, more women, it seems like, are facing that challenge, right?
Mhm. Yeah, or people, who the story, oh, I had an ovarian cyst and they took out my ovary, and now
Ugh.
you only have one remaining ovary. People who've had cysts in the past are at risk for having cysts in the future. You only have one ovary left. Maybe we want to consider, banking some eggs just in case.
So what would you advise someone that is confronted with like they're newly diagnosed and they're just, I mean, where do you even begin? You talk with your oncologist, you say, I'm concerned, and then they make the referral to you. Is that typically how it works?
Yeah. Mhm.
Okay. To a
Yeah.
fertility specialist and then kind of build that communication between the two of you.
Yep. Yeah, and then we say, hey, here's what we can offer you. As long as we have clearance from your oncologist that it's okay and safe to proceed, and you have the time to do this and delay your treatment. And there's more and more data coming out that's reassuring that majority of patients, do have time to do this. They do have time to delay those treatments, and this doesn't even significantly delay their time to treatment. A
Okay.
lot of times it takes a month or so to even get the chemo plan in place, for example. So there are many instances where a patient would be kind of waiting to get started regardless, and we can do this in the meantime.
Do you see this being talked about more? I mean, with fertility preservation, is it more in recent years people are kind of focusing in this area, or?
Um, I would say, ever since 2013, ASRM lifted the experimental ban on egg freezing, like going into 2013. And so it just became clear that the newer freezing methods for eggs were more effective. And there were, healthy live births coming from egg freezing. And so it was reliable technology, that was cost effective. And so ultimately, once that label became lifted, then this was offered, I'd say much more frequently and much more broadly. And it's been a push of things like the Oncofertility Consortium, Fertility Preservation, or the International Society for Fertility Preservation, various places, ASRM, who are helping spread the word and the education that this is something that should be offered to these patients that previously might not have. So it's good that it is being talked about more, as it should, because previously patients didn't have a great way to be able to do this, or didn't even know that it was an option.
Yeah. What's your experience? Are people just so grateful? Like they have this potential opportunity, to grow their family, right? To potentially like have that opportunity down the road,
Yeah, I mean, I think it's just so difficult because the thought of infertility on its own is hard. The thought of cancer on its own is hard. And then you put like two of the most depressing things you can possibly think of together. It's just unimaginable. So, I think patients are definitely, I'd say, grateful for the education, and the opportunity is there, and we're willing to try it, multiple different ways if that's something that they're interested in.
Oh my gosh, when I hear it like that, yeah. And just, I'm sure, you're people who are so young, like they might not be thinking about building a family at that time. And then you're all of a sudden confronted with, oh, I better think about this now, or I might lose my chance, right?
Right. Yeah. Yeah.
Are there support groups out there that kind of help people navigate through this in the area of, being confronted with fertility preservation?
Mhm.
Do you have any like potential?
I mean, there are certainly survivorship support groups, and there are infertility support groups. Are there specifically cancer survivorship and fertility support groups? I don't have a good answer for that, but it's a great question. look
How
into.
much of your caseload would you say is in this area compared to,
I mean, I would say we get several referrals a week.
oh, wow. And
Mhm.
all ages?
Yeah. Mhm. Up through age 45.
Okay. And for those you mentioned in the medical space, for say women physicians, they're in medical school. Can you just share a little tidbit? Like, what do you advise some women who are pursuing medical training and they're like, you want to talk about this if they're looking at delayed family planning? I mean, is there a certain age that you're like, oh, maybe by 30 or 35? Like, what do you tell people
Mhm.
to consider freezing your eggs?
Yeah. So, again, we talk about it like, oh, it's an insurance policy. Again, it's
Mm,
anytime you're delaying childbearing, there's a risk that there's going to be more of a barrier and risk of not completing your family or building it as you had envisioned. Okay. So usually once you get into your late 20s, it's kind of good to examine, okay, what's the trajectory here? Am I a relationship? Am I not? What do I think possible barriers would be? When would I envision wanting to start my family?
Okay.
And you can kind of reassess that every year or two. If you're getting into the early 30s and you can't see yourself trying to have kids within the next 1 to 2 years, that's when I would definitely recommend egg freezing.
Okay.
And because I'm not recommending at 22, you don't want to have eggs that you're paying for in storage starting at a time in life where, hard to know what the end of your 20s is necessarily gonna look.
Right. Right.
Okay. But we do know that egg quality is its highest in your 20s. And then you get into your 30s and we start to see that egg quality is going down a little bit every year. We start to see that impacting infertility, miscarriage, chromosomal abnormalities as you get more into your mid 30s, right? So it's not like it happens overnight when you turn 35. It's this slow decline from 30, to where about 25% of your eggs are chromosomally abnormal by the time you're 35, and it gets to about 50% by the time you're 40.
Can you repeat that statistic one more time?
25% of the eggs are chromosomally abnormal by age 35, and then 50% by age 40.
50% by age 40. Yeah.
So if you wait until later, you're going to need to freeze more eggs to potentially be able to have the same chances of a live birth. Okay. And the chances of having multiple live births with frozen eggs will certainly diminish as well. And so, having that good balance of young eggs to have better chances of live birth using them and potentially needing fewer to achieve that. And then you weigh that against the possible cost that you would be paying for these in storage every month, every year, and potentially never need them, right?
Wow.
Might conceive spontaneously on your own and never need them, or might decide that you don't want to have a family. So that's why, like any insurance plan, you kind of want to put as little into it as possible, but then hopefully have as big a return should you have to cash in.
Right. Lots to consider for sure. Thank you for helping guide patients through this. We need people like you for sure.
Yeah. And I think something else that people, I see is like a recent breakup or divorce where they thought their life was headed one way and then things change and suddenly these questions come barreling in. And I think often, people want to come in and see me right away. Okay, start this process right away. There's also a ton of trauma and stress that person's going through. So I think, okay to have the conversation, but doing this is such an emotional process. It's physically and emotionally demanding. It's okay to give yourself like a little bit of time to heal. Rarely does waiting 6 months have a significant impact on outcomes. And so, stress can certainly have an effect. And so I think it's okay to recognize that and feel like you don't have to do it like immediately. It's okay to give yourself a little bit of a break and try to heal. And then, we'll be here.
That's reassuring for women to hear and guys too. Like waiting 6 months, like it's not going to significantly impact you.
Yeah.
Well, thank you so much. And people can connect with you at what's your website? Shady Grove.
At shadygrovefertility.com.
Mm-hmm.
And anybody who wants to make an appointment or anything, there's a number there to call to get scheduled. And we, again, very passionate about fertility preservation and all the different aspects and ways that can occur and helping. So
thank you so much for sharing such amazing information today.
Yeah,
really
absolutely. Thank you so much for having me. I appreciate it.
Loved our conversation. Thank you.
Okay, take care.
Bye.